Now moving on to the next session, it's my great honor to introduce Dr. K. Krishnaveni, Professor and Head of Department of Pharmacy Practice, Vivekananda Pharmacy College for Women, Salem. Dr. Krishnaveni has more than 12 years of teaching and research experience in pharmacy practice. She holds her PhD from Pacific University and M.Pharm from the Tamil Nadu Dr. M.G.R. Medical University. She has authored over 67 publications, presented in national and international forums, and published a book in pharmacy practice. She has also successfully organized several national seminars and workshops. Her contributions to research are commendable, with patents including the Indian patent on anti-HIV drug delivery and a UK patent for a menstrual cramp relief device. She is a recipient of several awards, such as the Best Teacher Award in 2023 and the Dr. APJ Abdul Kalam Young Researcher Award in 2020. Dr. Krishnaveni has been a resource person, evaluator and chairperson in many national conferences and actively contributes to pharmacovigilance, diabetic education and community outreach. With such outstanding achievements, it's a privilege to welcome Dr. K. Krishnaveni as today's chairperson. It's truly a privilege to welcome Dr. N. Sudha, Professor and Head of Pharmacology Department, who has been a driving force behind the department's growth and success. The secret of getting ahead is getting started. Kindly turn your attention to the screen as we present a brief audio-visual introduction of our esteemed speaker. It's my great honor to introduce Dr. Vijay Kumar T.M., a distinguished academician and researcher in the field of pharmacy practice. He is currently serving as Professor and Head of Department of Pharmacy Practice at SRM College of Pharmacy. With more than 15 years of academic and research experience, Dr. Vijay Kumar has been actively involved in several prestigious programs and has also secured major research grants from the Ministry of Ayush and the Government of India. Dr. Vijay Kumar's contribution to research are remarkable, with more than 90 research and review articles, including publications in
high-impact nature index journals. He is also credited with 2 US patents, 1 Indian patent and 5 book chapters. His impactful research on vaccines, clinical pharmacy and drug safety has earned him several awards, including the Dr. P.D. Sethi Best Research Paper Award and the Outstanding Reviewer Award from Elsewhere Indian Heart Journal. As a mentor, he has successfully guided 5 PhD scholars, with 6 more pursuing their research under his supervision. His dedication to pharmacy education, clinical research and innovation makes him a highly respected figure in the academic and scientific community. We are delighted to welcome Dr. Vijay Kumar T.M. and we look forward to his valuable insights.
Good morning. I think it's Urdu afternoon. Good afternoon and very nice introductions, because usually the visual, even I looks, is very beautiful of my achievements that I am seeing on the screen. I'm really happy. Techniques in hearing issues. So that is part of diagnosis. So I am here. So major basic and important responsibilities of clinical pharmacist. I think most of the people who are going for hospital. So it is very basic only. But with some case scenarios, I want to explain you what are our major responsibilities in the healthcare. So that is my topic. So in the theme of national conference, enhancing healthcare. So enhancing patient healthcare. So that objective I am taking a major topic. So what's the impact of clinical pharmacist intervention in patient therapeutic outcome? So we know the clinical pharmacy and pharmacy practice is a area of pharmacy which directly deals with the science and practice of rational drug use. So that is a patented term for pharmacology and pharmacy practice, is rational medical use. So what it means? So we are here to ensure the rationality of the medication prescribed by the practitioner. Understand? So, this is a very common term for right indication, the right drug, right dose, right dosage, and right route of administration, and right frequency, and right duration is given to the right patients. That ensuring that is called the rational drug use or rational medication use. Okay, so you should understand about the pharmacist and the clinical pharmacist. Okay, pharmacist, indirectly involved in the healthcare team. So we can classify the production pharmacist who are working in the production, and quality chemist. Even we can say regulatory team, regulatory pharmacist, and R&D, research scientist. So those are also graduated either pharmacy, and they are working in different field, but they are indirectly involved in the healthcare. But clinical pharmacists are direct involvement in the healthcare. So that is a major difference between the pharmacist and the clinical pharmacist. So you can see this diagram, the cartoon. as per Indian setup, medical practitioner prescribe the medication. Right? Diagnosis and prescribed by the medical practitioner, as morning sir said. And nursing staff going to administer the medication to the patient. Understand? The sir said drug வேலை செய்யுது அப்படின்னாங்க. Okay. So everything as per Indian, this is the normal flow in the hospital. So why clinical pharmacist? So அவங்க என்ன பண்றாங்க? What clinical pharmacists do? Any idea? So you know usual setup in Indian setup. Medical practitioner, diagnosis and prescribe medication. Nursing staff going to administer the medication. So what clinical pharmacists do? Any answer? So very common topic, very basic. Is a pharmacist, is a clinical pharmacist in the hospital. So you should understand the clinical pharmacist role is very important. That too nowadays all NABH accredited hospitals need a clinical pharmacist team. So all the corporate hospitals, even in Chennai, all the corporate hospitals has team of clinical pharmacists. What they do? They have to why clinical pharmacy services? Clinical pharmacists should identify the drug-related problems. Prescriber, medical practitioner prescribe the medication. Nursing staff going to inject the medication or administer the medication to the patient. So in between, the clinical pharmacist should check the rationality or to identify the drug-related problems. That's a major role of clinical pharmacist in the healthcare. This all should know because all people are going for pharmacy students are going for ward rounds and doing daily taking real-time cases. But what you have to look for in the cases? You have to identify these are the major drug-related problems you have to look for in the case sheet or prescription. So first one is drug use without indication. We will see one by one with the example of case scenario. Indication but no drug prescribed, ineffective or improper drug selection, subtherapeutic dosage or overdosage, drug interactions and adverse reactions, monitoring of adverse reactions, medication non-compliance, non-adherence to the medication and medication errors. These are the very common drug-related problems you have to look for in the patients. As per the recent epidemiological data, the global prevalence of drug-related problems among the outpatients, you can see 5.3 overall, 5.3% of drug-related problems are identified in the OPD. Similarly, for incident of drug-related problems during hospital administered, that is inpatients. Inpatients, the ranging from high rate 15 to 16, 17, nearly 17% of drug-related problems are identified as per the recent report. So our clinical pharmacist responsibility is very, very important to identify the drug-related problems. So I will say, what is it called as intervention? It is another term in the pharmacy practice. So when I said rational drug use, so another term is clinical pharmacist intervention. What is called as intervention? That is a change made by the clinical pharmacist or recommendation initiated by the clinical pharmacist, which is directly related to address the drug-related problems of the individual patients, any phase of the treatment. You can say any change made by the clinical pharmacist for advocating the drug therapy. That is called intervention. So we have to look for more intervention in the patient. That is our major duty. So coming to one by one, drug use without indication. So very common drug-related problems in India. Drug use without indication. So what it means? Namely, drug use without indication. That is, the patient is taking medication, but there is no valid reason. That is drug use, but there is no indication. Yes? You can see very common. I will show the literature report also. In India, it's a very commonly found drug-related problems, drug use without indication. For example, a 65 year old male patient went to OPD for his illness as fever and common cold. After investigation, physician prescribed the following medication. In the case partner, so paracetamol 650, BD and diclofenac, cetirizine and cefixime. This I have taken from the one prescription only. So just you identified. Please, you people identify now. What is the drug use without indication here? There is no valid reason, but drug is prescribed. Can you able to identify? Please read the case scenario. Identify it. As per your knowledge. Please, anyone? Yes, please. Diclofenac. Very good. Okay, diclofenac. Good. Any other drug? Okay, diclofenac. Yeah, cefixime. Okay. So you can see the diclofenac and cefixime. Why? You said diclofenac சொன்னீங்கல்ல. என்ன ரீசன்? Pain வந்து சொல்ல. Okay. Very good. Pain there is no complaints. Okay. Patient side இருந்து related to body pain or headache இந்த reason சொல்லல. But diclofenac கொடுத்திருக்காங்க. But majorly paracetamol is sufficient. Paracetamol is sufficient because it has both analgesic and antipyretic activity. That's 650, please. But diclofenac here extra. This is also taken by OPD prescription but it is a diclofenac is extra. The mechanism action paracetamol analgesic effect, diclofenac effect, it falls on same mechanism. Inhibit the cyclooxygenase inhibitor. The old drug both. But and again extra drug has other adverse effects. It may cause other adverse effects. Similarly, we see cefixime 400. This is very common because even though we have antibiotic rescue program, other resistant program and everything, but it is the usual practice of a practitioner. But they have some valid reason for it. But as per This may cause extra burden as well as adverse effects to the patients. You have to look for it, but you can start initiate. That means the final approving authority is the physician only, but you can go healthy discussion with the physician on these drug related problems. Okay. So next, indication but no drug. Again, it is name itself is there. Indication present, symptoms present, but there is no drug prescribed. Yes, a 58-year-old female patient went to OPD for her illness as a fever, headache, body pain, severe vomiting. After investigation, physician prescribed the following medication: paracetamol, diclofenac, pantoprazole. But the left symptom is vomiting. Because sometimes it is not a intentional mistake of prescriber. Because of the heavy workload, they may have not taken the history properly. Understand? So these also you have to look into it. So which is sometimes it is for inpatients we have found lot of error like this. Sometimes patient may be already diabetic. When patient admitted for some other reason, and the reason என்ன பண்ணுவாங்க, sometimes வந்து history proper எடுக்காம அந்த diabetes இதே விட்டுருவாங்க. When they goes to new physician, அவங்க diabetic விட்டுட்டு what is the current issues என்ன இருக்கோ, they go for prescribing medication for it. So these are all some drug related problems we can found in patients. Another important, improper or ineffective drug selection. Improper or ineffective drug selection. For selection of exact drug is very tough because we have enormous drug in the market. 2 to 3 decades before, very limited drugs only in the market. For hypertension and diabetes can see limited classes, and in the limited classes, limited drugs only was there. Drugs now, but nowadays FDA every 6 months if we found latest update, new drugs are coming to the market. But it is very difficult for the prescriber to choose the correct medication for the correct indication. Understand? But diabetes now again new class of drugs are introduced. So it is very difficult for the prescriber. Listen, selection. Similarly, selection of dosage forms. Because of the novel drug system, it's very difficult to select. Understand? So inappropriate drug and contraindication and too many drugs for one indication. These are very common problems in the improper and ineffective drug selection. For example, a 45-year-old female patient has had asthmatic attack since 5 years. The patient is taking salbutamol, 2 inhalation, every 4 to 6 hours. The patient was recently diagnosed as hypertensive. So we'll be raised for that patient. So whether this propranolol is a correct choice of the patient, important. நம்ம propranolol correct choice ah? Any answer? What are the complications may arise if propranolol given to this patient? Very good. Okay, asthma patient ku beta blocker tharakudadu. Very good. Why? Yes. Because it's correct only. Please. Beta blocker என்ன பண்ணும்? It produce broncho diagra illa. Yes, that means beta present in the brachial muscle. It has physiological role என்ன பண்ணுது? Okay, glassing the brachial muscle. But beta blocker gives, it blocks the beta, so it causes constriction. So it may worsen the symptoms of asthma. Understand? So these are just simple example. So likewise, you have to check for contraindication. You have to check for past medical history and medical history as well as medication history before going to start the review of current medication. Okay. So next problem, drug-related problem, is subtherapeutic and overdosage. Subtherapeutic. For example, commonly if you take paracetamol 500 அப்படின்றது இருக்கிறதே மறந்து போச்சு இல்லையா? Do you agree with me? paracetamol 500 யாருக்கும் வேலை செய்ய மாட்டேங்குது. Is it? Yeah, everyone is going for 650. paracetamol 500 னு ஒன்று இருக்கு, but even prescribed practice also changed. Prescribed practice also changed. They are going for 650 because of even சாதாரண தலைவலி கூட பாத்தீங்கன்னா 500 கூட கேட்க மாட்டேங்குது. Understand? Because of the subtherapeutic dosage. That means you know that this every drug have this chart, this plot, time versus concentration in protein. There will be a point, minimum effective concentration and maximum toxic concentration. The minimum effective concentration, the drug or action touch பண்ணனும்னா it should reach to minimum effective concentration. When touch பண்ணா it produce the action. This subtherapeutic dosage, it reach out. It is not reaching the minimum effective concentration, so that therapeutic failure occur. Idhula mattum kedaiyadhu. If you see different dose selection is very important according to body surface area. So what dose can be given to the particular patient. So you have to check that dose is sufficient for this patient. When you can understand this thing, when you observe the case frequently, daily you see the case, whether after drug prescribed, drug kodutha onne you are monitoring the patient, whether next day or next day the symptoms are reduced or not. Illa அப்படினா the particular drug is not effective for the particular individual. So you have to do some kind of intervention there. Like maybe cause, major cause pathina, this we can see why the therapeutic failure occurs for the individuals. Major reason pathina, drug concentration present in the plasma. So other reasons pathina, pharmacogenetic reason, individual variants. But Similarly, if you go for overdosage, so drugs with narrow therapeutic index drugs. Okay, that means the minimum effective concentration, the interval between the minimum effective concentration and maximum toxic concentration is narrow margin. So this is very important because therapeutic drug monitoring requires for these drugs. You know it. Okay. Commonly we see digoxin, phenytoin. There are even the IP monitoring close monitoring of patient required protocol. The caution protocol. Why? If it reaches to, because in a narrow margin, the minimum effective concentration, the therapeutic window is narrow. Therapeutic range is narrow. If it reaches to maximum toxic concentration, it produces fatal effects because the phenytoin, digoxin not causes ventricular fibrillation, that is the cardiac arrhythmia. Okay, if it goes exceed, that's not the concussion with the problem. So close monitoring of patients required. So there your intervention is required. Okay, those who are taking the narrow therapeutic index drugs, because if it goes for overdose, it may cause fatal effects. So this is subtherapeutic and overdosage. Similarly, it's a normal, other than narrow therapeutic index drugs, we take normal drugs also, it may cause adverse reactions. So next, very important, drug interactions, detection of drug interactions. So you know that drug interactions can be classified into pharmacokinetic and pharmacodynamic and pharmaceutical interactions are there. But we commonly observe these pharmacokinetic and pharmacodynamic interactions. So practically, because when we used to, I studied during my PG, and I go for rounds, I used to carry this pharmacist handbook with me during my rounds. But nowadays we have mobile and you have installed a mobile app for checking the interactions. So it's simple. But when you are real time, you are observing the patient in the ward. When you are observing the inpatients, you are monitoring some different kind of symptoms. When they are taking multiple drug therapy, mostly we found in geriatric patients, because they are having prescribed multiple drug therapy. They are more vulnerable to cause these drug interactions. Geriatric pupils. So when you observe them, see, you can check via these are not only in the inpatients. You can see you have your prescription, grandpa prescription, you got to check from. You know that, you know it very well. But what you are doing, what you are checking is not actual interactions, you are checking the possible interactions. You can check via, this Medscap is freely available, you know that, and Micromax is subscribed one. You can check the interaction, you can list all the drugs in the medication chart, and you can check for the interactions, and you can give alert to the patient. That is called possible interactions. Don't mention that. Don't mention it's drug interaction. It's a possible interactions. When you see the effect in the patient, then that is called actual interactions. Otherwise, it's called as only possible interaction. You can give alert to the patients because it is categorized into major, moderate, and minor. Even the database only give the classification. So very simple. Everybody can do. But what you are doing next? Checking interaction is very simple. But what you are doing next? So after observing, when you found that the patient has major interaction, so you have to give the alert. You have to meet the concerned unit we also recently given advertisement from 17th onwards we are going to celebrate the Pharmacovigilance Week, right? Pharmacovigilance Week. So you know that there is no therapy without side effects. Ella drug side effects. Drug nale is monogram paathiruppinga IV or 6 drug paathiruppinga drug text la paathiruppinga edavadhu drug la pathina monogram la vandu side effects nil potrukka no side effects potrukka no side effects pathida drug paathirukkeenga no side effects. No side effects of drug because drug is a chemical substance. Drug is a chemical substance. It has its own therapeutic effects. Similarly, it is a disabled because it is crossing all the system. Drug potential it is not achieving the target. You know it. Okay. It is crossing all over the system. It is crossing the CVS, CNS, gastrointestinal system. Because it gives some impact on all the system. Then why you are taking medication? Then why you are taking medication? Remember the so drug, super drug, severe headache, simple I am saying. And the drug sapta thoroughly 5 minutes in a row. But அடுத்த 2 hours உங்க லிவர் போய்டும், லிவர் இம்பாக்ட்மெண்ட் ஆயிடும் அப்படின்னு சொன்னா அந்த ட்ரக் இருக்குமா? ட்ரக் சூப்பர் ட்ரக் 5 minutes தண்ணி சரியாயிடும். ஆனா அடுத்த 2 to 3 hours உங்க லிவர் போய்டும் அப்படின்னா அந்த ட்ரக் இருக்குமா? Then why you are taking medication? So all the drugs have its own side effects. Then why you are taking medication? Side effects are illa. Then why you are taking medication? Why patient is taking medication? Any answer? Super, very good. Very good. Okay, benefit is more when compared to risk. Always during trial also they will see the benefit. Benefit just because all the it has side effects, but when benefit is more, then that will be considered. So all the drugs have its own side effects. So side effects is minimal. So we are considering the drug. Understand? So what I am saying is this monitoring is a continuous process. Monitoring of adverse drug reaction is a continuous process. The reason நிறைய drug when அப்போ efficacy super சொன்ன drugலாம் இப்போ வந்து என்ன பண்றாங்க? நிறைய drug வந்து மார்க்கெட்ல இருந்து எலிமினேட் பண்றாங்க. Because of now it shows its effect. So it's a continuous process. That's why pharmacovigilance always just to initiate the reporting of adverse drug reaction. It's a prime duty. You just patient பாக்குறீங்க. So what you observe after, because not only therapeutic effect, you are seeing only therapeutic effect. So what the next day patient feels after taking medication. So நீங்க வராங்க, patient admitted ஆகுறாங்க. So doctor prescribed a group of medications. Based upon the symptoms and problems of the patient. So when the patient is taking the medication, so next day how the patient feel? So other than therapeutic effect, there are symptoms that should be noted by the clinical pharmacist. Understand? You have to go for deep history taking after medication. That's correct. So that should be noted. You should understand another major thing. There will be a difference difference is there. Adverse drug reactions, adverse drug reactions, side effects. These adverse drug reactions and side effects are similar to it. But adverse drug event, please understand this, adverse drug event is different. But event is something you found new, that may be or may not related to the reaction. Understand? Maybe suspected. But doubt பண்றீங்க, the drug may cause, the patient is taking good for medication, but next day பார்த்தீங்கன்னா patient வந்து okay, some kind of allergic reactions found. பண்றீங்க பார்க்குறீங்க, but you are okay, through your knowledge you are relating, you are suspecting ஏதோ ஒரு drug A or B is okay causing that reaction. That is called adverse drug event. That is called signal. Do you understand?
So because this PVPA, more than drug adverse reactions.
The pharmacovigilance of India wants more new signal detections, because these adverse reactions are already confirmed. They need adverse events. Whether you have to create some signals from your hospital or your clinics. That's what pharmacovigilance program of India wants. So so after drug administered, see the approach chart. After the drug administered, your patient develops a new condition or symptom that is considered as adverse drug event. So drug suspected, you are suspecting drug A or B that may cause this kind of condition. You are checking the literature, you are checking the monograph or literature. If it is already documented, then it is highly suggestive as adverse drug reaction. Next one, it is confirmed, already documented. For example, diclofenac, it causes gastric irritation. So well known. Elapril, that causes dry cough. It's already known. So this is called as highly suggestive adverse drug reaction. But we need more adverse drug event to be reported. And the formula, if you see, check the form, suspected adverse drug reaction form. So if it is, suppose it is not documented in the literature, you are suspecting one drug, you are checking the literature. If it is not documented in the literature, you are checking different sources, you are checking primary source, secondary source, tertiary source use பண்றீங்க, you are checking the literature. If it is not documented in the literature, drug is continued. If it is worsening the symptom, you are checking other possible causes. Either concomitant therapy maybe cause the reaction, or any other disease comorbid condition leads to this reaction. You are checking. When you continue the drug, if drug is discontinued, drug stop and if drug is discontinued, if symptoms reduced, that is called positive rechallenge. When again it started, symptoms reoccur. That is called positive rechallenge. So if there you can confirm, you can relate the drug with the reaction. So that should be reported to the PVPA. So you can, I think you have the ADR monitoring center is through that area monitoring center, you can go for reporting, or directly you can report to the PAPI. Okay, you have different sources are there. Okay, so healthcare professionals, that is, can report through AMC, Adverse Reaction Monitoring Center, or you can go to, directly you can, send to PPI. Now we have recent technologies are there. Through mobile app only you can go for applying the, reporting the adverse reactions. This is a very vital duty of clinical pharmacist. When you observe it, because don't ignore any symptoms. That's only PPI always, insisting. Even it is minor, you go for reporting it. You all should aware that all should be reported. Even it is minor symptoms. So now, because the form you know that, if it is form, through form you can send to area reporting monitoring center. There through which flow they will send to PUPI. Otherwise, you can go for adverse reaction reporting application is available in the even Play Store. You can install and you can go for reporting of adverse reaction. This is another important duty because all the drug has its own side effects. You have to observe the side effects when you are adverse event and you have to go for reporting of. So this is in our hospital we have found one adverse drug event, cefotaxime induced fixed drug reaction. We published because we have created one signal. This is from our hospital we have created signal. Likewise only, if more signals from throughout the world, if it rises, then again the drug it goes for re-evaluation, then it will be confirmed as adverse reaction. So each signal is very important. So this one, cefotaxime, that induced fixed drug eruption, this we identified from our hospital and we made as a case report and it is already published actually. This is the condition. After taking the cefotaxime, the patients caused this kind of skin allergy. Then we found that with the help of physician we found that is fixed drug eruption. Then we went for at least we have to make this, even that we reported to the area monitoring center and also we have published this case report also. So you can do both the things. If you observe something different or you observe any ADE, definitely you can go for case report. So another related issue, medication non-compliance. It's a major problem of medication non-compliance is the poor understanding of patient about the disease and about the drug. So, clean pharmacist, another important duty is to counsel the patient about the importance of medication and the complication of disease. So, both should be explained properly. The patient education towards disease as well as drug is very important. Then only they will adhere to the medication. Understand? So this is another vital duty of clinical pharmacist. Medication adherence, non-adherence automatically therapeutic efficacy irukadu. But there are a lot of reasons are there. But major reason, proper education towards the drug and disease. Insufficient education of the patient. And then you have to teach the patient related to disease as well as drug. So the clinical pharmacist intervention. So overall, what this interventions does? If you are giving proper intervention, if you are providing proper intervention, so what are the advantages? You see, if you are giving the patient education or medication management, if you have measurement and disease risk factors patient, and also it improves the disease control, and it reduces the drug-related problems. What I listed. It reduces the drug-related problems, and thereby we can improve the adherence to the therapy and reduce the mortality risk, and also reduce the hospitalization risk. So overall, it reduces the healthcare cost of the patient. So this is the major advantages of clinical pharmacist intervention. So you have to ensure now why clinical pharmacists should plays the role in between prescriber and the administrator. Is it clear? So these are some evidences in India, in Indian studies, after interventions, before intervention and after intervention. So this is already, we have, the mortality is reduced. So we check the study, clinical pharmacist intervention reduces mortality in patient with acute myocardial infarction. So that is the study conducted in India only. Sorry, that is the common in the India studies. We have, that is foreign study. The mortality is reduced around, it is reduced from 6.8% to 4.3%. Similarly, this is an Indian study. Assessment of clinical pharmacist intervention in drug therapy in patients with diabetes in tertiary teaching hospital. This is a prospective intervention study. So major objective is to identify the frequency of drug-related problems in hospitalized patients with diabetes. So major outcome drug use without indication is a very common issue. 34% out of total 189 drug therapy problems identified in the 151 cases. 151 cases cover பண்ணதுல 189 drug therapy problems identified. அதில் பார்த்தீங்கன்னா major drug use without indication is very common. I already said. It's evidence from the Indian study. So similarly, improper selection, I already said. Subtherapeutic dose followed by drug interactions, overdose, ADR, untreated indications, failure to receive drugs, so other problems. So the major problem is drug use without indication. So this is major intervention. What's the intervention done by the pharmacist? The study cessation of drug stop பண்ணிட்டாங்க 58% drug and the drug use without indication adha பண்ணிருக்காங்க stop பண்ணிருக்காங்க. So similarly addition, change in drug dose, change in duration of therapy, change in frequency. So these are the interventions made by the clinical pharmacist. You should understand this. இதெல்லாம் changes பண்ணிருக்காங்க. So the acceptance rate, suggestions accepted. So clinical pharmacist given recommendation only we can give, but approval authority is prescribed. So nearly 110, 58.2%, suggestions are accepted and therapy changed as per the Indian study. Is it clear? So your intervention is very, very important. It may, I already said, there's a lot of positive reasons are there. It gives very good impact on positive therapeutic outcome of the patient. So this is the outcome. Similarly, we conducted in our hospital, in SRM hospital, the pharmacist-led intervention towards management of type 2 diabetes mellitus, assessment of patient satisfaction. It's a prospective randomized trial we conducted in our hospital. Here, group A, usual care with clinical pharmacy intervention. One group normal care, the standard care with intervention, with our intervention, and next next group, usual care. The group A, we have significant improvement in the following levels. Okay, randomly for fasting blood glucose, HbA1c, average, and at least 6, up to BP, significantly shows difference before and after intervention. It's from our hospital. Similarly, adherence also improved. So after educating, adherence also improved. So this is the outcome. So another one more study we published in the current therapeutic research. The effect of telemedicine education on lifestyle modification of post myocardial infarction patient. This also, in this study also, group A, usual care with CP intervention, we have significantly improved in BP, RBS, FBS and total cholesterol. So these are the impact of clinical pharmacy intervention. This is evidence from the Indian study. So similarly, rehospitalization. In group A, percentage is 2% only, but in group B, 5% rehospitalization. So due to CP intervention, the hospitalization risk is reduced. So another evidence, the pharmacist's involvement in the patient care improves the outcome of hypertensive patient. This is also an Indian study. You can see the decline in the second follow-up of the intervention, significantly it is reduced. Even systolic blood pressure as well as diastolic blood pressure significantly reduced in the intervention group. Similarly, in quality of life also improved in the after pharmacist intervention. So these are the evidences I have shown, and how the pharmacist should be. For doing the intervention, the pharmacist should have these skills. That's very important. Without skills, you can't go for meeting with the patient as well as physician for doing the intervention. So you have knowledge on the disease, you should have good therapy skill, should have good laboratory as well as diagnostic skill and communication skill and patient monitoring skill and physical assessment skill and drug intervention skills and therapeutic planning skills, and you should have non-therapy, non-management skill also should have. So if you develop all the skills, you can go for more intervention and your contribution is very important to the healthcare. With this, I close the session. So any questions you can, because it's very basic, but because why I am saying this is your involvement in the day-to-day. You are going for hospital daily, you daily boring here, you are taking cases and do, at least daily one case, you go for thorough examination. That's very important. At least your knowledge you can discuss with your receptors first. Okay.
Thank you, sir. Thank you for the wonderful session. We will now move on to the question and answer session. Do you have a question? Please feel free to ask the questions, dear.
Good afternoon, sir. Sir, your session was more interesting, sir.
Okay.
Usually, in clinical sector, there are two types of treatment. One is symptomatic treatment, and other is diagnostic treatment. if we are employing diagnostic treatment, the adverse effect can gradually decrease. No, sir. For example, in foreign countries, if you are encountering with a fever, they will give paracetamol and they will use serological parameters like blood and urine for analysis and then start the treatment procedures. But in India, irrational use of drugs, like in first slide we have seen the cefixime.
Yes.
Then diclofenac. Which is better, sir? Whether symptomatic treatment or diagnostic treatment, which would decrease the adverse effect.
You only give the answer. Diagnostic treatment is okay, it's correct. But as per Indian setup, it is not suitable. Okay. So only our interventions are more important.
Sir, one more.
Yes.
In clinical side, we can also implement also diagnostic treatment, not only in hospitals, but in small clinics. So we can research.
Yes.
And there are any evidence that irrational use of drugs are causing mutations? Is there any evidence?
Actually, even here in our Indian setup, even patient mentality also different. What patient thinks now, once the problem comes, I want to get rid of the problem. Understand? So similarly, if physician mindset also like that only. Do you understand? இங்கே வந்து இல்லை, நீங்க போனீங்கன்னா உடனே ட்ரக் சரி பண்ணிடுங்க, அவ்வளோதான். இது வந்து because here our physician patient mindset has to change. அப்பதான் நம்ம வந்து physician mindset change ஆகும். Okay, but இங்கே வந்து யாருமே அப்படி இல்லை. Even for mild issues are not there. They are directly going to pharmacy and getting the medication. அது என்னன்னே தெரியாது. Again, okay, both of the people has to change the mindset here. Understand? Okay, good. Okay.
Any other questions? Any other questions, dears? Okay, sir. Myself, I'm having the questions.
Yes, ma'am, please.
Before reporting an area to AMCs, is there any soft source available now to confirm that areas are ADEs?
No, actually, there is now actually they are developing it, but we can go for this relationship. No, we can go for we have WHO scale and we can have the NRHO scale to check whether it is probable, is made related to the drug related to the reaction or not. We can check like this now. But AI software is developing now. Actually, we are developing. Even many even academic as well as industry side, regulatory side, they are developing that by using AI. But maybe soon it will reach to market. Okay.
Thank you, sir.
Okay.
Thank you, sir, for your enlightening and crystal clear session.
Thank you.
And you have covered all the basics of clinical pharmacy services, start from the service and what are the intervention can be provided by the clinical pharmacist. So everything you have covered. I hope definitely this session may benefit the students and they may apply in the real-time life also. And one thing I have to conclude with this. Three main things we have covered.
Yes, ma'am.
So one is whatever the drug has been selecting, the drug should be, the benefit should be overweight the risk. That is the most important that we have covered. And regarding the area, even though the area is minor and it is well known by everyone, that should be reported. Still, the minor area is underreported by all the healthcare professionals. So that one thing. And main objective of our services is pharma are not touching the economics. So the cost reduction have to be a benefit to the patient. That is most important. I think this 3 is the most important take message for the participants. Thank you.
But once we do the intervention properly, automatically I have mentioned the chart, ma'am. Healthcare cost will be reduced by the given finalized. The output is correct only. In the last slide I have mentioned that overall it comes to reduction of the healthcare cost. One slide. Yes. Reduce the healthcare cost. Actually, when we achieve all those things, automatically reduction. Of course. Okay. Thank you, ma'am. Thank you.
Thank you.
Actually, really thanks to the management and principal sir and our other organizing team for giving this wonderful opportunity to me. Thank you.